All right, good afternoon, everybody. Thank you for joining us for our Grand Rounds presentation today on an introduction to lifestyle medicine for family physicians with a focus on nutrition. There will be some interactive questions, so if you could please log into Grand Rounds from your personal device, you'll be able to participate. Don't forget to mute it so you're not going to get feedback if you're viewing together in a group. Well, I'm Lauren Gibson Oliver. I'm a family physician and board certified in lifestyle medicine. I am the program director at the UIMS Little Rock Family Medicine Residency Program, and I also lead the lifestyle medicine residency curriculum for our residents here in Little Rock. Something that is well known and celebrated in lifestyle medicine is collaboration. So in that spirit, I am joined today by two of my lifestyle medicine colleagues who will now introduce themselves.
I'm Julie Roulier. I actually am in Batesville joining you guys today. Very excited to share with you some issues, or I'm actually really very happy to share my passion for lifestyle medicine. And I have been working with UAMS now, Associate Director, for about 4 years. We do not have a curriculum, so I'm very happy to hear everything that Dr. Gibson Oliver has to say so that we can use that. I think it's going to be super practical today and very happy. And with that, I'm going to introduce you guys to Dr. Drobina, who is also part of the lifestyle medicine team, but has kind of more in-depth culinary skills.
Hi, I'm Gina Drobina, and while my day job is in transfusion medicine, one of my passions is lifestyle medicine, and that's because of its effect on my own health. And so I became certified in lifestyle medicine in 2018. And then in 2022, I obtained certification in culinary medicine through the American College of Culinary Medicine. And one of the things that I love about culinary medicine is it's really the practical application of the nutrition pillar of lifestyle medicine for me. And so while you all are learning more about lifestyle medicine throughout this talk, I'll be here in the teaching kitchen making one of my favorite plant-based recipes that we teach medical students in our longitudinal elective, and that's quick red beans and rice. And so you'll be checking in with me periodically throughout the talk, and we'll walk through some of the important steps in the recipe. And I'll turn it back over to Dr. Roulier to begin.
All right, thank you. One of the things we're missing is actually the smell as the interactive part of this. So next time we might actually challenge everybody to do this so that we all get a better taste. I have said I'm technically challenged, so I'm going to work on this. Dr. Gibson Oliver is actually helping me out incredibly by being the person who's changing my slides for me. So I appreciate that. And that keeps it easier for everybody else. So first of all, our objectives this afternoon are to share our passion for one, but also to define lifestyle medicine and to identify lifestyle medicine pillars. There are 6 of them and how they relate to disease and wellness, to understand the evidence for lifestyle medicine, develop ways to integrate lifestyle principles into your daily family medicine practice, and also to give you some practical pointers. We can move to the next slide. We're hearing a lot about lifestyle medicine now. You can read about it in the press, both medical and also the popular press. Occasionally you hear about it from patients. And now more specifically, the AAFP is putting out a strong push to get more people involved in lifestyle medicine. Both the AAFP and the ACLM, which is the American College of Lifestyle Medicine, are working towards building a healthier community through partnership, shared experiences, and shared mindset. Next slide. Actually, we'll stick with this slide. This was in 2021. The AFP prepared a publication with a free 1-hour CME course entitled Incorporating Lifestyle Medicine into Everyday Practice. As a good kind of introduction to that, the next year in 2022, this was published by the Journal of Family Practice. And in collaboration with the ACLM, it's 120 pages of complementary digital information. It gives you the introduction to the field of lifestyle medicine. There's multiple reviews and practical briefs and encouragement. It is all peer-reviewed by the Journal of Family Practice and is all evidence-based. Next slide. And even just last month, since January 2024, the AAFP has actually opened up a dedicated resource on its website, very pretty. And I have actually not gotten a chance to go into this very much. And for people who are interested in going to a live course, the AAFP is actually sponsoring an event in March, and registration is open now. Next slide. This one I don't want to spend very much time on. Most of you are aware that Arkansas has long been near the bottom of the list as far as state health outcomes and national rankings. Next slide. This is not due to the lack of knowledge or skill of our state's physicians. As you know, there are well-entrenched ways of eating, ways of working, lack of exercise, and often a serious lack of motivation on the part of patients. That malaise can actually influence us as physicians who struggle to manage multiple variables to meet our metrics. Because we have so many opportunities, we are very good at treating diabetes and hypertension and cardiovascular disease with new medications, new gadgets, and new technology. Next slide. But even with our best intentions, the problem of chronic diseases doesn't go away. 60% of Americans have chronic disease, and 4 in 10 Americans have 2 or more chronic diseases. The chronic diseases, including heart disease, cancer, diabetes, stroke, and Alzheimer's, are the leading cause of disability and death in our country. 72% of Americans are overweight or obese, and 1 in 3 Americans have prediabetes, and 90% of them are not aware of that. A recent review from the Future Healthcare Journal of the Royal College of Physicians in England affirms that, quote, "Too many physicians and patients alike may believe they are victims of their genes and they are destined to become chronically ill and dependent on pharmaceuticals." I see this way too much in my own clinic. Next slide. If we could eliminate poor diet, sedentary behavior, and smoking, we would prevent 80% of heart disease, stroke, and type 2 diabetes, and 40% of cancers. Working towards restoring health with a whole food plant predominant diet, 150 minutes a week of moderate exercise, daily relaxation, 7 to 9 hours of restful sleep, no smoking, and regular connection to positive people is how lifestyle medicine helps provide and reverse treatment and reverse chronic diseases. Next slide. This I picked up a few weeks ago. Usually I like to give some picture, and most of the time I'm giving it most of Arkansas. But this struck me. If you look at the horizontal axis, it's the diagnosed diabetes cases over time, and obesity is from pink to blue on the vertical axis. So in 2004, you kind of got a lilac colored United States. And then, we've known what causes obesity and diabetes, and we've worked on it, but you can see just a huge increase in color to the point where we mainly cover with blue and purple in almost all the states, and a lot also focused down in the South. Next slide. So what Americans eat is what's making us sick. This is a plate which is not usually in any of the, hopefully in any of the education we do in schools, but it's probably more about what a lot of us would eat. So in order to improve our health, we need to decrease this. Next slide. So how do we as physicians move Americans and specifically Arkansans to better health? Is there enough time and enough energy to make real changes? And can we convince our patients that they do not have to expect obesity, diabetes, heart disease, and early death just because their parents and grandparents carried the burden of these chronic diseases? Lifestyle medicine focuses on the root cause of chronic disease. Lifestyle advice is often the first recommendation on major guidelines, including diabetes and hypertension. However, advice differs from the skills needed to help patients achieve behavioral change. Next slide. The American College of Lifestyle Medicine is our college that actually helps promote lifestyle medicine. Lifestyle medicine is a specialty. Boarding is through the American Board of Lifestyle Medicine. It focuses on therapeutic lifestyle interventions as the primary modality. It is evidence-based and whole person, and it treats and reverses and prevents chronic disease. Next slide, please. Examples of lifestyle medicine are listed here. These are pretty well known. They weren't specifically from the ACLM, but these are things that have been researched for quite a while. Well-known examples include the longevity studies in blue zones, which are 5 zones in the world that have people who live well into their ages of 90s and 100s. And living well doesn't mean just that they get to that age, but they are actually living extremely well and healthy until the point where they're in their 90s, and some people into their hundreds. And so they've researched and looked at ways that those lifestyles could be promoted in other places. Loma Linda, California is the only place in the United States. And it actually has a very high percentage of people who have a whole food, plant-based diet. The next study that is very well known is the Mediterranean diet study, which is an example of studying a Mediterranean diet, which is high in good fats, high in exercise, high in fish, that is associated with the only one that's associated with primary prevention of cardiovascular disease. And then my own personal favorite is the DPP, which is the NIH Diabetes Prevention Program and the ongoing outcome studies. These studies were started in the 1990s. Lifestyle interventions of weight loss of only 7%. So if you have a patient who's 200 pounds, it could be a 5-foot-tall woman or it could be a 6-foot-tall man. So obviously 200 pounds, if they lose 14 pounds is 7% of their body weight, which if you're a 5-foot woman, you're not going into a slim state, but you would decrease that plus moderate intensity activity of 150 minutes per week, outpaced metformin, preventing progression to diabetes over 10 years by 58% to 31%. Next slide. All recommendations by the ACLM are evidence-based, as noted in this consensus statement from last year, 2023. Lifestyle medicine is informed by an established and rapidly growing evidence base of peer-reviewed research that includes systematic reviews, randomized trials, large cohort studies, and other scientific publications. Current evidence supports lifestyle medicine as the foundation of managing chronic non-communicable diseases. Next slide. A key goal of the ACLM and the AAFP is that physicians be empowered to share the evidence and skills to teach their patients how to make changes. These skills include behavioral change techniques such as motivational interviewing, developing SMART goals, compassionate personalized care, integration of care providers from other places, including dietitians, health coaches, personal trainers, and social workers. The patient is an active partner in lifestyle medicine, and education is provided through evidence-based solutions. Next slide. We as family physicians are exceptionally well poised to wield significant influence to help patients make change. Key aspects of family medicine that make us ideal are first contact access, a comprehensive approach, and coordination and personalization of care. It is in our family medicine DNA to forge relationships with patients. These relationships often begin before patients have an illness, unlike associations in specialty clinics. We have the advantage of treating the whole person, and we are with our patients through sickness and also health. The relational bond fosters trust over time between the provider and the patient. Most of the time, we as physicians are coaches for our patients, giving instructions and encouragement as they leave the office and until they return the next time. Next slide. And now I'll hand it back over to Dr. Drobina.
Okay. This is the recipe that I'm working on from today, and it is available in culinarymedicine.org. One of the skills we teach first is the importance of mise en place, or everything in its place. So I've got all of my ingredients here and measured out. Lauren, if you can close screen sharing now, I'll show my cutting board. I've taken my onion, celery, and green bell pepper and cut them into small pieces of similar size to ensure they cook evenly. The oil is hot, so I will add the vegetables and spices and let them cook until they are soft, while Dr. Roulier tells you more about the pillars of lifestyle medicine.
All right, can you smell it? Because I almost can smell it. The 6 pillars of lifestyle medicine are whole food, plant-based nutrition, physical activity, stress management, avoidance of risky substances, restorative sleep, and meaningful social connections. Next slide. We're going to spend the next 40 minutes talking about whole food, plant-based nutrition, so we can move on to the next slide. which is physical activity, should be regular and consistent and includes general physical activity, which would be associated with taking care of the house, physical jobs, getting up, moving around several times during the day, but also purposeful exercise. And the goal is 150 minutes per week of moderate intensity exercise. And if I was in the conference room right now or the classroom, I'd be asking everybody how much exercise it is. 150 minutes of moderate intensity is being able to talk while you are exercising. Sedentary behavior has negative effects, but any positive movement actually has positive effects, and it can be minimal. Next slide, please. Stress management is associated with improved health and productivity, decreased anxiety, depression, obesity, and immune dysfunction. Identifying negative stress reactions helps you put into play positive stress responses while you identify coping mechanisms and learn some stress reduction techniques. Next slide. Avoidance of risky substances is well known to actually would help decrease the risk of chronic diseases and death. Treatment takes time, many approaches, and often many attempts. Addiction medicine needs patience and support from a provider, and having those long-term relationships is very, very beneficial. Next slide. Restorative sleep means 7 to 9 hours per night, recommendations for adults. Sleep delays and interruptions cause sluggishness, low attention span, decreased sociability, mood, deep sleep, caloric burn, and feelings of fullness. It increases hunger and insulin resistance and also decreases performance. So working on good sleep is definitely important. And our last pillar is meaningful social connections. This improves physical and mental health and emotional health. It also helps leverage the power of being able to help one another kind of make your goals. So even groups like Bunko groups and bridge clubs, accountability partners, and dietary changes, running or walking buddies are all hugely helpful for the lifestyle changes. So how America Eats could be better. What we're going to talk about today is the whole food plant-based lifestyle with increasing whole plant foods, fruits, vegetables, whole grains, beans, legumes, nuts, seeds, and water. Decreases your risk for chronic diseases and will improve the overall lifestyle. And from here on, after we check in with the kitchen a couple more times, we will actually have Dr. Gibson Oliver.
Okay, I think it's my turn again. So now that the vegetables are softened and I've added garlic, I'm going to add the beans. I'm going to add some low sodium vegetable stock. And I'm going to add a couple of bay leaves. And so we'll talk about sodium a little bit more during our next check-in, but a couple of tips that might help during this step are to rinse your beans if you can't find low sodium, and then choose low sodium broth if at all possible. And with that, I'll turn it back to Dr. Gibson Oliver.
All right, thank you, Dr. Roulier and Dr. Drobina. So yeah, where do we start? Where do we even start to put this into practice? So currently we do have USPSTF recommendations for intensive behavioral health nutritional counseling and physical activity for overweight people with chronic disease. And this is a grade B recommendation. We also have a USPSTF recommendation for nutrition and physical activity counseling for people with no chronic disease and no risk factors based on their readiness to change. Unfortunately, it's a C recommendation, so can be done with or without. I always tell the residents it's a C is a conversation, so can not enough evidence to be fully there as the full recommendation, but definitely can help. So current evidence that we have is the Dietary Guidelines for Americans. This is jointly issued by the U.S. Department of Agriculture and the Department of Health and Human Services. They update guidelines every 5 years. They are based on recommendations from the Dietary Guidelines Advisory Committee, which is composed of nutrition and medical researchers. In the US, after they released this scientific report, the secretaries of the USDA and Health and Human Services actually take public comments. And when they're releasing the dietary guidelines for Americans, they actually consider both the evidence and public comment. So what we see here is the MyPlate, which many of us are familiar with. This is based on the dietary guidelines for Americans from both the advisory committee and public comment. So unfortunately, this allows the food industry and other special interest groups to influence public policy and can really create discrepancies between recommendations and the scientific evidence. So what does the evidence say? One of the things that is true is that nutrition studies are hard. They're challenging because everybody needs to eat. You have to eat in order to live. So most major nutrition studies will be intervention studies or large prospective cohort studies that are published in high impact journals. The best evidence comes from studies that have really intensive dietary change interventions. Some of the seminal studies for lifestyle medicine are the ones that demonstrate evidence of disease reversal or remission. Because of their intensive nature, they're often smaller in size but do tend to have pretty good quality evidence. There's also studies that are supportive of lifestyle medicine treatment that show promising results relevant to disease treatment and cost savings. So we'll review just a couple of the studies of the evidence just briefly. So since we do know that lifestyle medicine is evidence-based, these are some of the studies that is based on. So the first one would be the Dietary Portfolio for Treatment of Hypercholesterolemia. So this was a study that had a very low saturated fat diet that was high in plant sterols, soy protein, viscous fibers, and almonds. Patients that were treated with the diet actually had a decrease in LDL cholesterol that was not statistically different from treatment with another group that was just treated with 20 milligrams of lovastatin. The DASH diet, or dietary approaches to stop hypertension, is something that many of us are familiar with. We talk about it with our patients all the time. It was originally actually done in two parts. The first one showed participants that were on a combination diet, the DASH diet, of fruits, vegetables, low-fat dairy, low saturated fat, low total fat, and cholesterol. And they had lower blood pressures compared with the control group. And the control group had just the standard American diet. The later DASH studies actually compared two groups, one on a DASH diet and one on the control diet, but they all had varying levels of sodium in that diet, low, medium, and high. They actually found that both diets that were on the lower sodium arm had lower blood pressures, which is not a surprise to us, than those that were on the higher sodium arms in both diets, the DASH or in the control diet. The Ornish lifestyle intervention for coronary artery disease is one that's cited a lot in lifestyle medicine. It was a study that was done for secondary prevention of coronary artery disease. It included a lot of the pillars of lifestyle medicine, so diet, exercise, stress management training, tobacco cessation, and group psychological support. The intervention group was compared with usual post-MI care, post-coronary artery disease care. They had a reduction in coronary artery stenosis that actually continued to improve over the 5 years that study was followed. And then the control group had an increase in the same time period. The next one is the Ornish lifestyle intervention for prostate cancer. This one's interesting. They had the study followed men that had prostate cancer who opted for active surveillance over usual cancer treatment. Instead, they chose intensive lifestyle interventions. And after 1 year, they actually found gene expression was altered in the intervention group compared to the control group. The Lion Diet Heart study looked at secondary prevention of coronary artery disease with the Mediterranean diet over the American Heart Association Step 1 diet. So again, secondary prevention post-MI, and it showed the Mediterranean diet arm had fewer composite cardiovascular disease outcomes and the results maintained actually for the 4 years that those participants were studied. The Esalen plant-based diet for coronary artery disease included a very low-fat plant-based diet, which was shown to reverse and prevent major cardiac events in the 177 patients that were adherent to the diet for almost 4 years. Among those patients, they had events or major adverse cardiac event rates of less than 1%. They did follow a few of the participants that did not stick to the diet. It was only about 21 that they were able to follow, but 13 of them experienced major adverse cardiac events, which ends up being about 62%. The diabetes prevention program, Dr. Roulier spoke about that. The Complete Health Improvement Program, or the CHIP program, focuses on plant-based dietary interventions with cost savings. And they found to be that it was effective in treating type 2 diabetes, as well as producing a positive return on investment in just a few months. And then finally, the vegan diet for treating diabetes was a 22-week randomized clinical trial of 99 subjects with type 2 diabetes. They compared participants that were on either a vegan diet or the American Diabetes Association diet, the ADA diet. And those that were assigned to the vegan diet significantly improved their diet quality as measured by the Harvard Alternative Healthy Eating Index, despite the fact that they actually increased their carbohydrate intake. Those that were taking the American Diabetes Association diet did not improve their diet quality at all compared to their baseline. So based on the evidence, the American College of Lifestyle Medicine proposes this plate. This is the alternative to the myplate.gov plate. As you can see, there's half of the plate has fruits and vegetables, which is similar to the myplate.gov. However, the differences are in the other side of the plate. We see a quarter of the plate being plant proteins, and then a quarter of the plate being whole grains, and then of course, drinking water and using herbs and spices to flavor the food. Now, this is a significant departure from what most of us ourselves eat and also what our patients are used to eating. Presenting this to patients can be incredibly intimidating to them. And at first, they may feel like it's just not possible and not even want to start. But, as we know, change is really hard. So it's important as family physicians and lifestyle medicine practitioners to be empathetic to the fact that change is very difficult. And if we approach our patients with a lens of understanding as we're coaching them through lifestyle management of chronic disease, it will be better for the relationship, better for the patient, and better outcomes. So how do we start? As with anything in medicine, we can't come up with a plan until we first make an assessment. So I'll go through the ABCD method of a nutritional assessment. Now, as a preface to this, I know that working with patients on lifestyle changes is very time consuming. Often it's not something that we can do in a 20-minute visit where there are other items on the agenda that the patient wants to address, that we want to address. So I find it's often necessary to either bring the patient back for a visit just to do the assessment and talk about lifestyle changes, or utilize your team members that have this training. So A stands for anthropometrics. We start with weight, height, and BMI. We have these very available to us during each office visit. One thing that was not a typical measure that we have is waist circumference. And waist circumference is not just important for us to help with risk assessment and modification, but also it's one of the first places where patients will start to see changes. Even before they start seeing changes on the scale, they'll see differences in their waist circumference. So this can be very motivating to patients. B stands for biochemical data. So when we are working with patients on lifestyle changes, or even patients with chronic disease, these are things that we are going to normally get anyway. Nothing really different here. C stands for the clinical assessment. So we'll have a lot of these: age, sex, medical history, surgical history, vitals, physical exam. These are all parts of their normal clinic visit. The parts that may be a little bit different and added to the nutritional assessment would be talking about their activity level. So how active are they? Even just, doing things around the house, how much exercise and formal exercise do they get? What's the intensity? And as Dr. Roulier said, it's often good to ask them how can they, or how are they able to talk during their physical activity can kind of help us gauge how intense it is. And then getting a really thorough nutrition history. So thinking about and asking about what their weight history has been. And this is really getting into the weeds with them. So asking them what their highest weight, what their lowest weight, when they felt the best, how much has their weight changed over time, how many fluctuations do they have, are there certain medical or social issues that happen that have changed their weight or have affected their weight over time, and how much has it changed up and down over time. And then you also want to know about history of deficiencies, any GI diseases, any concerns for malabsorption. Have they had bariatric surgery that could affect their absorption? Do they have Crohn's or ulcerative colitis that could affect these as well? And then finally, D stands for the dietary assessment. So really getting an idea of their daily intake of solids and liquids. I know that I'm often surprised at how much patients get their calorie intake from liquids that they drink. So it's really important to ask about both. The 24-hour recall is something that we are all very familiar with. We do this often in clinic, but is really a helpful tool that we have to help the patient and us to understand what their food intake is like. And then I'll often give patients a little homework assignment of doing a 3-day food record. I think 3 days is pretty manageable for most patients, and it gives us a good idea of what their daily intake is over kind of a normal week. So after getting a good nutrition history for a patient, making sure that they're ready to make a change, the first thing that I usually talk about with them is whole foods. So whole foods are unrefined, minimally processed in such a way that it's not going to substantially diminish their nutrient content. One way that I like to talk with patients about this is saying something like, think about all of the things that needed to happen to this food before it got to your plate. So in this case, we look at the apple. It was picked from the tree, cleaned, shipped, purchased, and now it's sitting in front of you. And then as we move down the line of processed foods, it's harder to really imagine everything that happened to the food before you're consuming it. In general, the more whole the food, the more nutritious it is. But food processing isn't always going to be bad. For example, the applesauce is minimally processed and can be easily traced back to its whole food origins. However, we're moving down the line here. We get more into the ultra processed foods, such as this apple fritter here, where we see more ingredients like hydrogenated fats, starches, added sugars, as well as other additives like artificial flavoring, dyes, preservatives, and stabilizers that have been added to this. With this, many of the nutrients that originally come from the apple, like fiber, vitamins, minerals, that were there are not there, and as a result of processing are removed. So what is our caloric intake by food processing as a country? So currently about 70% of the calories that we intake as Americans in the US are in the form of processed and ultra processed foods. So that's a lot. Thinking about, 58%, almost 60% of the foods that we eat, all of those calories are coming from foods that have been ultra processed and have had a lot of their nutritional value removed. And you look down even at the minimally processed foods, we see that only about 14% of those are from whole foods like grains, root vegetables, legumes, fruits. And those are even including things like juices and refined grains. So really we're getting a lot of our calories from places that we probably shouldn't. So kind of looking at ultra processed foods and the impact that they have, there was a study done in 2019 that found that diets that were rich in ultra processed foods cause excess calorie intake and weight gain. So they took 20 adults, which is a small study, but they put them on either ultra-processed diet or an unprocessed diet for 14 days in a controlled setting. The diets that were presented to the participants were matched for calories, fat, sugar, fiber, and macronutrients, and the participants were able to eat as they wanted. While this was a small and short study, the important takeaway is that those that are eating an ultra-processed diet ate about 500 calories more per day than the ultra-processed diet or the unprocessed diet. And then subsequently, you can see they also gained weight on this diet. So food packages is an important concept in lifestyle medicine, and it's important to think beyond a single nutrient when we're talking about food and talking about whole foods with patients. We want to consider the entire food package when determining the relative healthfulness of a food. So although some foods that we have are high in a particular nutrient, the rest of the package may not be ideal. So an example would be whole fat milk or 2% milk. Yes, they are a top source of calcium in the American diet. However, they're also one of the top sources of saturated fats. So you want to ask the question, if you're trying to get more of a particular nutrient, is there a better source or a better package to get those? Briefly looking at macronutrients, all macronutrients are going to be present in all whole foods, just in varying proportions. There's really no single food that's equivalent to a single macronutrient. This table shows the macronutrients, their primary functions, and the recommended daily allowances or adequate intakes. So briefly, carbohydrates, they're our primary source of energy for the brain. They're help us with our calories. Recommended daily allowance is about 130 grams per day. Fiber improves laxation, satiety, lowers the risk for coronary artery disease, and also helps us to maintain our normal blood glucose levels. The recommended amount is 14 grams per 1,000 calories consumed. So thinking about if we're doing a 2,000 calorie diet or around there, we're thinking about 25 to 38 grams of fiber per day. Now, protein is a major structural component of all cells. We know it functions in enzymes, membranes, transport carriers, hormones. The recommended amount of protein for people to get is about 0.8 grams per kilogram of ideal body weight. So this ends up being about 45 to 55 grams per day, depending on the ideal body weight. And then fats, we know it is important. We can't cut out fat completely. Fats are important for many of our bodily functions, and we do need to get some fats per day. So now we will start with a question for the audience. How many grams of protein does the average American consume per day? And go ahead and answer on your devices. All right, so see a couple coming in here. So looks like most of the people that are answering are saying about 30 grams. About 43% of people have said most are consuming 30 grams of protein. And then it's split between 50 and 75. About 8% of people said 100 grams. So the answer is actually 100 grams. So the average American consumes 100 grams of protein per day. Now, if we go back to that previous table, we remember that the recommended daily allowance is about 46 to 56. So Americans are consuming a lot more protein than recommended. So in the US, protein is typically associated with animal proteins and protein powders, but it's important to remember where those proteins come from. All proteins and amino acids, which are building blocks of proteins, actually originally come from plants and microbes, from the animal that we're eating their meat coming from the plants that they eat. Labeling food as protein is really a misnomer. When we think about animal protein specifically, the majority of the calories from animal proteins are actually coming from fat, not from protein. So all proteins, regardless of their source and their origin, are digested the same in the gut. They are broken down into their amino acid building blocks, absorbed by cells, and then used in the body. When we look at our protein food packages, animal versus plant protein, we can see kind of the other stuff that's included in these food packages. So animal-based proteins are going to have saturated fat, cholesterol. They do not have fiber in them, and they tend to be higher in calories because of the amount of fat that's in these proteins. And then looking at plant-based proteins can have a lot more benefits. They have fiber, antioxidants, vitamins, minerals, phytochemicals, and water. So a question that inevitably comes up when talking about plant-based eating with patients is, well, how do you get enough protein? We kind of live in a almost protein-obsessed society, and people are always very concerned about getting enough protein when they're on a plant-based diet, or even switching up some plants for plant protein for animal protein. So really, as I mentioned, all the essential amino acids actually originally come from plants, and many of them, as you can see here, have adequate protein. So remember, the dietary intakes that are recommended are really only about 50 per day. So you can see from this chart that actually that's pretty easy to achieve when just eating plant-based proteins. All right, so we'll start with our next question. On average, how much fiber does the average American consume? We'll give it a minute for the poll to come up. Right, so looks like about 4% are saying the high, 39 to 44, about 20% saying 25, 50% is saying about 12 to 18, and then 30% 5 to 11. So the answer is 12 to 18 grams. So thinking about, again, the recommended daily allowance, that would be 25 to 38. So you can see that we're getting a lot less of the actual fiber than our bodies need. All right. So carbohydrates, quality is important. Complex and unrefined carbs from legumes, vegetables, whole grains, and fruit really differ in their health effects from the refined carbs like white bread, white rice, etc. So when I talk with patients about carbohydrates, I like to kind of put that also in the context of whole versus processed foods. So carbohydrates, we know they're made up of fiber, starches, sugars. Fiber, we know, is essential to gut health and immune function, and the higher intake is associated with lower risk of coronary artery disease, lower insulin resistance, and lower rates of colonic disease. Fiber, unfortunately, often gets removed during the processing, and sugar is added to these ultra-processed foods. We have naturally occurring sugars in whole foods that are healthy in moderation, and those are not associated with adverse effects. However, the added sugars from processing have been shown to increase inflammation as well as increase insulin production. Starch, briefly, is a healthy complex carbohydrate. So foods that contain starch can either be healthy or unhealthy, just depending on the degree at which the food is intact and refined. So when we think about counseling, as far as carbohydrates go, it's really helps to understand the glycemic index, can really help with harm reduction and behavior change by helping the patient understand the quality of the carbohydrate and where it kind of falls on the glycemic index. So we know that high GI foods are going to cause rapid elevations in blood glucose, whereas the ones that are lower, 50 and below, are going to have a more sustained elevation and more gradual elevation in blood glucose. So many things contribute to what the glycemic index of a food is going to be, but fiber, the level of processing, the type of starches in the food are really going to be the big ones. So our next question is, what is the leading source of saturated fat in the American diet? Put this up here. Wait for some answers to come in. All right, so we've got about 25%, 23% are saying beef, 4% eggs, most are saying cheese, and cheese is correct. So although we have more saturated fat in beef, cheese is consumed much more ubiquitously than beef, and so cheese really is the leading source of saturated fat in the American diet. So it's not all fats are bad. Almost all whole foods contain fats in some way or another. So it's more about the dietary pattern and really looking at the food package to be the important piece of when we're thinking about reduction of cardiovascular disease, diabetes, and other chronic diseases than really total fat. Foods that contain predominantly mono and polyunsaturated fats should really replace those that are saturated fats. And then we should really try to avoid trans fats at all costs. Here's some examples of these types of fats. So the monounsaturated and polyunsaturated are kind of what are normally considered the healthier fats, present in some oils and have better health benefits. The saturated fats are in meats, elevate cholesterol and increase LDL. And then our trans fats are the ones that are in fast foods and packaged foods, really create inflammation, increase bad cholesterol, lower HDL or good cholesterol, and also increase the risk of heart disease. So I'll touch quickly on micronutrients. They are the chemical elements or substances that are essential in small or minute amounts for growth and health. They are vitamins and minerals typically of what we think about. So there's a common misconception in the US that we need to have supplements in order to maintain this balance. Many studies have shown that a variety of whole foods actually helps achieve your micronutrient balance better than supplements or taking supplements instead of eating the whole foods. It is important to remember people that are eating a fully plant-based diet, completely plant-based, will probably need vitamin B12 supplementation at some point. And then the other thing about micronutrients to think about is they really should be prescribed as food families. So instead of saying you need to eat more potassium, think about eating more dark leafy green vegetables that have potassium, calcium, and magnesium, or eat more dark berries and fruits that contain polyphenols instead of prescribing things like just the micronutrients specifically. And really the take home for the patients is that eating a rainbow of plants is going to really cover all of your micronutrient needs. I don't want to move on from micronutrients without talking about sodium. As we know, sodium has a major impact on many chronic diseases and is a major contributor to negative health outcomes when consumed in excess. Sodium comes mainly from processed, packaged, and restaurant food. So the average American consumes about 3 grams of sodium per day, which is about twice of what the American Heart Association recommends. And I am going to go to Dr. Drobina very quickly to have her take on sodium specifically about this recipe.
Thanks, Lauren. So when I saw that Dr. Gibson-Aller had included the slide on sodium, I had to jump in because the value of eating at home is something that we really emphasize with our students, and it's something that we can emphasize with our patients as well. The nutrition information that you see on screen is from a popular fried chicken chain, and the top line is a side dish size, so around 1/3 of a cup. And the second line is more comparable to what you would get in our dinner size portion in the recipe we're making today. The restaurant version weighs in at 2.5 times the calorie count. Sorry, 1 second. Of the version that we're making here today, and then more than 10 times the fat and almost your entire daily dose of sodium at 1,740 milligrams versus our version's 260 milligrams. And that's a pretty incredible difference. So I'll turn it back over to you, Lauren.
Thanks, Dr. Gerbina. All right. So how do we help patients achieve meaningful change is really the big question. The first thing that we need to do is really identify their readiness to change. And I know in family medicine, we talk a lot about identifying how to identify when patients are really ready to make changes. Patients that aren't ready to change are not going to change no matter what we say or do. So it's in our jobs to assess, encourage, give information, be a support, a coach, a guide, but ultimately it's going to be up to the patient. But it is important for us to have steadfast persistence, patience, and willingness to continually engage with them and support them when they're at any stage. So whether they're pre-contemplative or anywhere along the trans-theoretical model, we need to think about being there as their guide and their coach and their cheerleader. The one thing we can do is write a nutrition prescription when they're ready to make this change. So I'll go through a nutrition prescription as thought by the American College of Lifestyle Medicine. So the components of a nutrition prescription are going to be a T, A, and F. So you can think it's fat backwards. T stands for type of food, A stands for amount of food, and F stands for frequency of food. We have both positive and negative prescriptions. Both are important and both are necessary. Positives are usually easier to start with. So thinking about adding foods in or adding more of one type of food or eating more of one type of food. And then our negative prescriptions would be consuming less of a certain food or making a replacement or swap for certain foods. All nutrition prescriptions, regardless of what they say, how big or small, should have SMART goals. Ideally, these are being elicited from the patients, and they are really something that they can meaningfully change. We know SMART goals are specific, measurable, achievable, attainable, or action-oriented, realistic and relevant, as well as time-based. But just some examples of some SMART goals would be eat 2 or more pieces of fruit per day. Add 1 more vegetable at lunch and dinner. Cook dinner at home 2 or more times a week. Start eating breakfast with whole foods like oatmeal, fruit, or nuts. Eat 1 cup of brown rice instead of white rice for dinner. Eat an apple and 6 almonds for my evening snack instead of a pint of ice cream. Exchange 1 soda per day with water that has a splash of juice in it. And then, or something even bigger, like eat a whole plant-based meal for dinner once a week. The one thing, just kind of as we're wrapping up, patients do not exist in isolation. We really need to think about when we're considering lifestyle changes and talking about these things with the patient, we cannot ignore how their social determinants of health really affect their health, their care, and their ability to even engage with any type of change. So it's really important to ask the questions and understand what their life is like. What struggles do they have? What are their barriers that they have to healthy behaviors? And then asking them about their values, what's important to them. And then one more thing when talking about dietary change is really being sensitive and asking about how food plays a role to them socially, culturally, and emotionally. So just finishing up here, small changes can really lead to big results. Patients do not have to make 180 changes, go fully plant-based, or do any of these things all the way in order to see results. small changes matter, and it's important for us to be there to encourage and celebrate even the smallest wins with our patients. So with that, I will check in with Dr. Drobina one more time, and then we'll open it up for questions.
Thanks, Lauren. Here's our final plated version of the dish showing an actual serving size. One way that I think we can help make transitions to a healthier diet easier for our patients is to provide them with foods that are familiar, but better. And I think this is a great example of how we can take a dish that traditionally has fatty pork to add flavor and recreate some of that savory goodness with smoked paprika. And it also helps us maintain cultural sensitivity for our Southern patients. And you can see in the dish the red beans and rice on top, and then I've got some brown rice underneath. And I do plan to eat this for lunch. So I'm very excited. Thanks.
All right, so we do have a couple of questions, so we can go ahead and get started with those. The first question is, have any of you incorporated this lifestyle into your own lives, and how has it helped you? Thank you. Dr. Roulier, would you like to start?
I actually do, but I kind of like this kind of food anyway. So, and having done kind of a low fat diet for years, I love to look at recipes. So it was not hard for me to move into that, but I haven't maintained it. I have other family members who don't want to move into that quite yet. Once my kids were out of the house, it was a lot easier for my husband and I to have 2 or 3 nights a week where we might have just a whole, have a vegetarian meal. And the other things I tell my patients are things is exactly like what Dr. Drobina said, is you can substitute kind of very high spicy foods for some of the flavors you like, such as if someone's going to put cheese into something, I say, well, get a very sharp cheddar cheese or Parmesan cheese, which you can use smaller amounts of to get a boost of flavor.
I agree, and I think I also kind of have have always kind of eaten this way. I was very fortunate to grow up in a place where this eating this way was sort of the norm. And so this was kind of my worldview growing up. And so I think as I've moved around and experienced different cultures and worked in different places, I've realized that, you know, this is a really helpful way of eating. I know that I feel better when I eat plant-based. I know that my patients, when we talk about these things, when they make those substitutions, they feel better. And so I definitely can tell a difference in my own life for sure.
And I'll pipe in. I've gone more or less plant-based at various points in my life. I've been completely vegan in the past. Currently, I would say I'm probably more flexitarian. And I think I can also sometimes tell a difference in my health based on, you know, how strict I'm being, not necessarily just with the plant-based part, but especially with the sugars and the ultra-processed foods. So the answer is yes, but to more and less degrees.
Great. We do have a message from our chair, so I'll address that one first. Next, so I will just talk briefly about the lifestyle medicine residency training that we do in family medicine. So in Little Rock, we have the lifestyle medicine residency curriculum, which is put out by the American College of Lifestyle Medicine. And that includes 40 hours of didactics and 60 hours of practical training that we give the residents throughout their 3 years. And so this is, they're learning these essential pillars of lifestyle medicine and how we can actually translate this into patient care. We know that nutritional counseling or nutritional learning in medical school is less than a day in the entire medical school time that we go through all 4 years. So we're not taught how to teach patients about lifestyle, even though it's the #1 treatment for all of the chronic disease guidelines. And so it's really great to be able to offer this training to our residents to help our patients, to help our patients in the state to live healthier lives. And there is opportunity and there's plans to disperse this throughout all of the family medicine residencies within the state and share this knowledge and make sure that we are training family physicians that are skilled in lifestyle and counseling lifestyle and actually treating patients with lifestyle for the chronic disease, so that maybe we can actually bump up our rating a little bit on the national level and not continually be at the bottom in Arkansas. My next question would be, let's see, there's a question, how do we expect patients to make changes when the morbidly obese doctor is standing in front of the patient drinking Coke? That's a really tough question. I think that, we have to think about the things that we say to patients and not, put it out in a paternalistic way, saying, do as I say, not as I do. So, if this is something that you want to incorporate into your practice, then it is important to kind of, look internally and think about, are there ways that I can make the change? Or additionally, you can share your struggles. I think, patients can really do respond to when we share the fact that, we're not perfect. We can say all these things and I know the right things to say, but I know that I've struggled with eating this way. I've struggled with, this and that. And so it's important to kind of have that shared experience with the patients. Dr. Roulier, would you like to comment on that?
Yes, I do think, and one of the things that the lifestyle medicine asks you to do is actually look at yourself. So it's been a couple of years since I finished the course, but it is definitely, it makes you think. I really enjoy, to tell you the truth, when I talk about something and then people who are residents, other faculty will come up and say, I really want to try that, because it can be small steps can make a big difference. But I do think, especially, we live in a small community, but we were just talking with the people who are helping us with this presentation. It's like, well, I live just down the road at Ball Knob, and so we're in the same community. And I think people who are living with you know you a little bit better, and they're going to look at how I'm at Walmart buying stuff and I know people are looking at my grocery cart, or they're covering up their grocery cart. So I think, walking the walk is important, but also sharing your struggles if there are things that are hard for you.
I think the only thing I would add is just the extension of compassion to our fellow physicians who are struggling. I think we are broken people living in a broken world, and often in medicine working within a broken system. And so I think there are a lot of stresses and issues that come up for us as physicians as well. And one of the things that I love about lifestyle medicine is the emphasis on wellness for physicians, and that we can make these changes in our lives ourselves and reap the benefits along with our patients and becoming better examples for that. And so I really encourage people to focus on their own wellness. And we do have a wellness curriculum that we've got a grant for through the Chancellor's Circle for the GME, the residents. And so I would, encourage you all, if residents that are on the line, to please consider joining that as well.
Can I add one more little thing? Because I think one of the things I like about the Mediterranean diet, and also what you were speaking about, was also that you're putting in some positives. So thinking about putting in good foods, and with that, you're putting that in, and it's kind of pushing out some of the bad things. So even those little changes, changing to one night a week where you might eat, maybe instead of hamburger, you're actually going to eat, I was going to say chicken, but that still has all the fat. So you're going to eat your red beans with paprika. So that little change actually pushes out that, 1,000 calorie and tons of fat hamburger. So those changes can make significant steps.
Great, and I know we still have a bunch of people on, so we'll just go ahead and answer a couple more questions. Let's see, we didn't talk about intermittent fasting, which has shown good results. So any thoughts to share on that? So yeah, I think, there's lots of evidence on lots of things. And there's lots of different ways to eat and lots of different ways to, get the food or put it in packages, put it in the different times of day. Lifestyle medicine doesn't really kind of focus on that. It more focuses on the food that we eat and the nutritional content. But I think it's also just important to know if intermittent fasting works for them, then I think we need to encourage it. I think if, really encouraging where they're at and kind of meeting them where they are, giving them the information and being their cheerleader. Dr. Berlia, did you have anything with that?
No, I agree.
Yeah, I completely agree. And I think, timing is something that may work for some patients to help, condense the amount of time that they're able to eat foods. I think, my focus still remains on the quality of foods that they eat during that time period. So you can intermittent fast, all you want. If you're still eating cheeseburgers and bacon and eggs and et cetera, you're still not going to see the cardiovascular benefits that you see from a plant-based diet.
All right. Next question is lifestyle coaching a part of lifestyle medicine? Would you recommend providers take a lifestyle coaching class during their career so that they can be a cheerleader as you discussed? Did one of you want to take that?
I would love all of us to become coaches. I think I did a culinary coaching course, and excuse me, I think that it was very beneficial for helping me to communicate in a way that people could hear. And I think that's the most valuable thing that I really gained from coaching.
It definitely is part of what they do, teach us in lifestyle. And honestly, I did completed my lifestyle training during the pandemic. So did a lot online. But I think that we as physicians are already kind of in that position as coaches. And I think but learning how to really respond to the patient and to what their needs are and figuring out how to help them is going to be probably a definite important part. And that's beyond just the lifestyle changes that we'd like them to make.
Yeah, I agree. And I think the lifestyle medicine, the ACLM has a lot of different types of courses that you can do in person, live, online. They have, kind of shortened ones or even extended ones. You could even become board certified as already being a family physician. And we have also want to put a plug for some CME that we have from lifestyle medicine that Dr. Drabina can maybe talk about just a little bit. And really just, I think it's definitely out there, and the ACLM is a really great resource for finding those. They also have a wonderful conference every year, which apparently has the best food of any conference that is out there. And so it's something that is also that we can consider as family physicians. So Dr. Drabina, would you like to talk about the CME?
Sure, happy to. The IPE office partnered with me to get a grant to do lifestyle medicine CME via IPE. And so we and Dr. Gibson Oliver is one of the authors on one of our modules, on the pediatrics module. And so I think you might find them valuable if there are certain pillars or populations that you would like to learn more about with lifestyle medicine. It is on our UAMS Cloud CME website. And up to a certain number of participants, it's free. And so get it while it's free.
Great. I think that's all the questions. I just want to say thank you all so much for joining today and just allowing us to share our passion for lifestyle medicine and for how we can make meaningful changes with our patients. So thank you all, and we'll see you soon.